Hi, Clarice. Oh, Stanley, get back. Stanley, hey. Let's see. So see when, like, I can't tell who's on. I mean, I guess I could if I.
If you click the participants, then it'll show on the right. It's just small.
Oh, all right. Who's that? What are these people?
Supriya is one of our student fellows.
Oh.
I have not met.
Must be a medical student or something. Graham's always one of the first ones on.
Morning.
Hi. Oh, I have to turn that back on. I watch my phone, no question will go off during it every single time. I have them muted, but all right, good morning. I'm gonna get started. It's 8. So we have 2 visitors today. One is someone you know, and then the other one, come here, is someone that you don't know. This is my dog Stanley that I brought to work today. It's not bring your dog to work today, only if you're Paul Michaels. So he's not allowed to be here, so he's hiding. So you didn't see anything. All right, so this first case is a 67-year-old woman. She was found to have a left breast architectural distortion at 1 o'clock on the screening mammogram. And then she had a follow-up ultrasound, which was suspicious because it showed an ill-defined and hypoechoic mass, posterior shadowing. That's a very suspicious history by ultrasound. So then this is what I sent you. And so like this core, just taking it core by core, this core to me is not suspicious. You know, it looks like there's dilated, medium-sized to large glands. There's some calcifications that we're not looking for calcs, we're looking for a mass. So, you know, that is helpful in the sense that that's often more associated with an atypical proliferation, especially if the nuclei are rounded like this. So this to me already looks like kind of flat epithelial atypia. If I just had this. Let me see, why is this not? So just kind of moving in other areas. This architecture is getting a little weird, where you've got kind of a larger, looks like a duct, and then you've got some smaller ducts on the outside. It's not clearly malignant. You kind of look for glands going into the fat. That kind of makes you wonder a little bit, something like that. And look at that. I just noticed that. That almost looks like a giant cell, but I don't think that's a giant cell. I think that that is probably a gland right next to a fat cell, which that in and of itself is very suspicious. And then I sent you a picture that looked like that. This looks like a pinwheel. This is not a normal architecture. This almost by definition is invasive ductal carcinoma. It's a very tubular pattern where you get these kind of pinched off spaces at the periphery. That looks pinched, that looks pinched. This one up here looks pinched. That's nothing that's necessarily specific, but it is something that's kind of characteristic of especially really well differentiated ductal carcinomas that have a tubular pattern. So this is all, to me, very suspicious. Now, when you see calcs and tubules, that's less likely to be an invasive carcinoma only because, you know, calcs form with something that's slow growing, but these well-differentiated ductal carcinomas can be tricky because they are slow growing and because you will see calcs in them. This too also looks weird. You know, this looks a little haphazard. what is this? I mean, what is this supposed to be normally? I don't know what normal structure in the breast is supposed to be. Same here, you've got these glands just imperceptibly in the fat. This is not normal. Now you get that in microglandular adenosis, but with that, even though you don't have a myoepithelial cell layer, they're very well rounded and they have these eosinophilic secretions, and these obviously do not. So I was convinced this was invasive ductal carcinoma. So but this is something, as convinced as I was, you've got to get some sort of myoepithelial marker stain. So here is the P40. So let's go to some of these areas in the fat that I pointed out. So you can see the normal lobule here. And then you've got oh, you know what? That's why it's turning lighter. It's when I put the arrow. So I'm going to do that. I'm not going to use the arrow. I'm going to use this. So here you've got the normal looking lobule, and then this is all invasive carcinoma. And you would never pick something like this out on H&E and think that that's cancer. These you would, I think, but these larger ducts, I think, don't look like cancer. And then when you go back to that core that had the stuff that I said didn't look like cancer at all, look at that. You've got, this is normal, this is benign. All these things that look like flat epithelial tibia, that's all invasive cancer. Now the question could be, is this P40, which I'm using a nuclear stain, which can be kind of attenuated in some in situ proliferations. Is it just not staining? Well, no, you should see something with that. Here you see absolutely no staining. So even though these do not look like an invasive carcinoma on an H&E, this is all invasive carcinoma. So I usually do a couple myoepithelial markers. I like to do P40, and I also like CK56, which nobody uses. But I think it helps for two reasons. One is if you, especially for some of these things where you're wondering, like a low-grade invasive ductal carcinoma, those often have like ADH in the background. And so ADH versus UDH, CK56ER are really good. In fact, that's Rosen's triad. So Rosen, who's a famous breast pathologist, it was tubular carcinoma, columnar cell chains like flat epithelial tibia, and which can kind of merge into ADH, and lobular neoplasia, LCIS, is because they're often together in one slide. It's called Rosen's triad. So this is my CK56, and I really like it. Here's that same area that I first showed you, where you see the staining around what looks like a normal lobule in kind of a very linear pattern, which these cytoplasmic markers do, and then the actual tumor is negative. Now, yeah.
It seems like that makes it easier to see the attenuated cells. So it's lighting up the cytoplasm.
So it does, but it can be kind of messy. So I mean, look at that's kind of too dark. And so yeah, I think it does make it easier, but to me it's less specific. But like this looks pretty clear. But if this was all I had, CK56 is not one of these traditional markers. I have kind of found over the years that it's helpful, but like that I don't know. Like look at like this, I don't know I don't think this is benign, but yet that looks like it's showing some staining.
Yeah.
So I think you kind of have to be careful. But I think I use it in conjunction with a nuclear stain like P40 or P63. And then this is smooth muscle myosin heavy chain, which a lot of people like, everyone talks about in meetings. I think it's really messy. And it kind of does that same thing where, it looks like if you just had that and this was all you were looking at, I think some people would say, oh, well, there's some attenuation, but it looks like there's some intact state. We know that this is all invasive carcinoma, except for that, which is much different. So it's almost like E-cadherin with lobular carcinomas. You allow for there can be some staining in lobular carcinomas for E-cadherin, but you need to see it adjacent to something that's normal to know that it's attenuated and it's, indicative of a lobular phenotype. So this is a well-differentiated invasive ductal carcinoma. On the core, I said with tubular features because it looked very tubular, but you don't make these special type diagnoses on cores. I don't, because you need the whole thing and you need like a certain percentage of tubular. It's like 90%, mucinous 90 to 100%, et cetera. And it's important because if you give them that diagnosis, technically they don't need to do oncotype because those are considered such low special type carcinomas that they would not, a lot of times they don't give them chemotherapy and they don't give them radiation. So don't get an oncotype because it doesn't matter if the score is high, they are by definition not supposed to get chemo. So you have to be careful. You really need to be sure when you're making that diagnosis. So this is the lumpectomy that was done. So we know where the biopsy was. And then this is the invasive carcinoma, which is so bland and deceptive. Like, so this, just the architecture, this is all invasive. It has to be based on the architecture, but you would never look at any individual gland, never, and say this is invasive. Isn't this awful? This is awful, awful. Imagine getting a core that you just get a little bit of this. You would, and I think 90% of people would absolutely miss this, and it's going to the margin. So, I mean, maybe that is kind of getting more like pinched off. Maybe you could guess that that's invasive, but even this, like, usually you don't have such well-defined cytoplasmic luminal borders with invasive carcinomas. They're usually more pinched off. These aren't pinched off. They're a little branching, but that doesn't mean anything. Like, this looks like this is perfect flat epithelial atypia. And like, look at that. This just looks like flat epithelial atypia. So I didn't believe it. I looked at it and I knew based on the architecture that it was cancer, but I just didn't believe it. I did the stains again, which I'm so anti doing these stains because I don't want to waste the money and I don't feel like I need to. And I feel like sometimes they make things more complicated than they should be. So here you have what looks like what is clearly benign on P40. And then look at that. That is flat epithelial atypia, but it's not. It's a flat epithelial atypia-like invasive carcinoma, which is basically not described. You get cribriform carcinoma, tubular carcinoma, but this, if you had a core biopsy of this, nobody would get stains on this, except maybe the CK56, but even that, you would have to have some epithelial proliferation. You don't get those stains on FEA versus columnar cell hyperplasia without atypia. So I just thought I'd show this case because it is the most well-differentiated, bland-looking pattern of an invasive ductal carcinoma I've ever seen and probably will ever see. So let me just show you, I don't know what else I'm going to show. Okay, so full disclosure, an hour ago, I was about to drive to work and I had taken these slides home to kind of go over them and make sure I had them in the right order, and they all fell out onto my garage floor. So I hurried up and put them in what I think is the right order. So this may be a little disjointed at times, but so this is good flat epithelial atypia. And I think the thing to notice is that it looks kind of lobulated because these are basically lobules that are expanded at low power. Maybe you could say, oh, well, this is infiltrated looking. Yeah, but these are flattened. This is just a duct, and then, you can look for myoepithelial cells. A lot of times they're kind of hard to see in the columnar cell lesions anyway, because they kind of push them off to the side, especially when it's atypical like this one. But I mean, notice this is just normal flat epithelial atypia. It has that same kind of undulating, irregular outpouching. The one thing I will say is this is associated with what looks like more cellular intralobular stroma. So that would, be a hint that this is benign and not a case like what we have. But cytologically, this looks very similar. Rounded nuclei, apical looking, eosinophilic cytoplasm with snouts, loss of polarity, rounded nuclei. This is not invasive carcinoma. This is not UDH. This is flat epithelial atypia. So they used to think flat epithelial atypia, I think, was more significant than it probably is now. Years ago, I remember I went to a Surgical Path course in Hawaii in 2007, and Schnitt was talking, and he was talking about flat epithelial atypia, and he was kind of the one who really, I think, gave it the name and described a lot of the features, and he was saying all these need to be excised because there's upgrade rate of like 30% on excisions. I think that that is no longer considered to be true. Most surgeons will not excise this if it correlates with the radiology. Like usually you see it in the context of calcs. If they targeted the calcs, if there's no calcs left on the mammogram after they do the biopsy, then they will not excise it. They should not.
So they monitor.
Yeah, they'll just kind of, continue to screen her. So just to show you in contrast to like a tubular carcinoma, the differential for most people is usually radial scar. I think radial scars look very different. It looks like spokes on a wheel. And then as you get to the tire, the glands or ducts look more dilated, more irregular. They look like UDH. Sometimes in radial scars, they can look like ADH. You should be very concerned if you're going to call it ADH and what looks like radial scar. You're probably wrong. It's probably UDH. Get the stains. But the thing I wanted to focus on that I feel like a lot of people don't talk about or notice is that in radial scars, when you see any of these compressed small ducts, they are always in this middle. This one is not that elastotic. A lot of times they're more sclerotic, but you should not see those small glands as you get out to the periphery. And that architectural pattern of radial scars that you would appreciate at low power is what is most helpful for radial scars. Now, when you get a really big one, it can get a little more complicated because the architecture gets a little more irregular and not as uniform. So this is one that is probably better considered a complex sclerosing lesion when it's not like the definite architectural pattern. You get areas that look kind of like papilloma. See how that looks kind of like introductal, almost like sclerotic papilloma. A little more haphazard. These are usually bigger. You call them a complex sclerosing lesion. Essentially, it's the same thing as a radial scar. In this one, I thought that this was benign, but because the architecture was a little irregular, and again, if this was a tubular carcinoma, you would expect the intraductal proliferation next to it to be at least FEA or ADH. And so that's the other soft thing that helps you when you see something like that. The stroma is not necessarily helpful. You can get stroma that looks just like that in a tubular carcinoma. So that should not necessarily, make you completely downplay the possibility that this could be an invasive carcinoma. But this should give you pause. If you see what looks like really good UDH, where you have maturation of the nuclei, kind of streaming of the cells along the periphery, smaller, cells, very nuclear irregularities, not the uniform round nuclei. If you see that, and then you see like a tubule next to it, you're probably in the setting of a radial scar, because if this was really a carcinoma, this would be ADH or low-grade DCIS. But, this was, I did this one in Texas, and I got 40 just to show it would never have probably done this. But I thought that this was helpful because look at how attenuated this P40 stain is. It's not as dense as you see in like completely normal ducts that are outside of the radial scar. And so that's why I get a little nervous when people rely on these stains in something that looks like a radial scar, because you can imagine getting a section where you might not have any, or it may be really, staining very weakly, and then you would call something like that little tubule invasive carcinoma, especially if you're already suspicious. So you really have to, have your pretest probability intact and know that this is, for all the reasons we talked about, this would be like a classic radial scar. And then, okay, yeah, now this, pay attention if you're not paying attention. So this is a very, very important case. This is a case I had here last year. And this, to me, looks all invasive. So they're really solid nests that are kind of branching sheets, irregular outlines, not like well-defined outlines to these groups. They look kind of haphazard to me. It's kind of crushed, so it makes it a little harder. It's very inflamed. The stroma looks desmoplastic. The cells are cytologically malignant, lots of atypical mitotic figures. The other thing I often look for is I look for entrapped like collagen fibers inside these areas to make sure that this is not some weird expansile DCIS. However, I thought that this case was really interesting because as you move, that's clearly invasive. The architecture is clearly invasive. As you move over here, I could see a lot of people, and I've seen several people over the years see the inflamed reactive stroma and say this is all desmoplastic stroma with these little nests, and this is all invasive. None of this is invasive. This is all cancerization of globules. And what you need to pay attention to is don't look for myoepithelial cells. You're not going to see them. Look for the really well-defined prominent basement membranes that are kind of almost refractile, hyalinized. See, even this looks irregular, but it still has a rounded contour. So it's this rounded contour that should make you suspicious that this is not invasive carcinoma, that this is DCIS, basically cancerization of globules. Because see, even this is all DCIS. This looks different. This is not. And so that's important because I think I've told you before, I had a case in Texas that almost got me fired because I caught this. I was taking pictures for Tumor Board. A pathologist and another pathologist that she showed called all of this invasive carcinoma, and they did the stains as you would, including HER2. It was HER2 strongly positive. The woman was about to get a port the day that I reviewed the slides, and I saw these and I said, no, this is actually DCIS. And I got the stains, got them back the next day, and confirmed with the surgeon that it was all DCIS. I told the pathologist, told her, you got to call the surgeon, you got to do an amendment. She felt that I was being very rude, which I was not. I was just correcting her because it was an issue of time because the patient was about to start chemotherapy the day of the tumor board, which was the next day. And so I told her, you got to do this right now. You got to stop what you're doing. I already called the surgeon. I already told her, but you have to fix your report because this is a big deal. She's about to get chemotherapy for DCIS. And she complained that I was being rude, and they kind of investigated me and slapped me on the wrist and said, you talk with your colleagues better. I'm like, fuck you. That's how I'll talk to my colleague. I'm saving my colleague from a lawsuit. I don't fucking care how I talk to them. So anyway, and I wasn't talking the way I am now. So I was as appropriate as I can be. Now, this is why this is so difficult. So here's P40. This was my case here. This is not that case I'm talking about. You can see this is intact. Notice the staining all around. Now, this is where it gets tricky. What if you had this and you were trying to do, the same thing? Max, what do you say? What do you think about this?
So
is this in situ or invasive?
This, by the same, this looks more in situ.
Yeah, that's
more in the center.
That's the trick. It's not. It's not in situ. This is invasive. These P40 cells, these are invasive cells. Look how ugly they are.
Yeah.
Look how big they are. Now compare them to that. See how small they are? And it's what can happen with these, like basal phenotype, they can express these, high molecular weight cytokeratins, P40, and a lot of times it's like they're really screwing with you. They go to the periphery like a myoepithelial cell would, but they're not. These, look at the size. These are tumor cells. And CK56 looks exactly the same. So again, you can see how well defined this is for the myoepithelial cells, how they're small, they're bland. You don't even see the cells really. You just see like the outline, almost like mascara. And then you move to what it's the, that's still DCIS. That's still DCIS. That's not. But then look over here. This isn't either. This is all invasive. It's just CK56 stains these basal phenotype carcinomas, and sometimes ones that aren't even basal phenotype it can pick up. This case was actually HER2 positive. And the DCIS was HER2 positive. So if it was all like that, I would have run into the same problem that my colleague did, several years ago, where I would have called this invasive. She would have gotten, Herceptin, Perjeta. Those are very cardiotoxic. Then they would have done the excision. Someone maybe else would have reviewed it and said, oh no, this is all DCS and it was on the core. That's a very easy lawsuit to win. And I know a pathologist from UCLA who I went to medical school with. She became a pathologist and she made this mistake and got sued, unfortunately, appropriately. So anyway, but it's a very easy mistake to make. All right, so let's move on to case 2.
Gotta make sure the cells that are staining are in the right place.
Not just the right place, the right size.
Right,
Because sometimes they are the right place and they're
Right.
just, they're big and they're tumor cells. So 52-year-old woman underwent routine cervical screening without a history of prior abnormal PAPs. Was found to have ASK-H by PAP with positive HPV-16. Colposcopy and biopsy were performed. Let's see. So this, it looks like, I'm going to max this out. This looks like mostly ectocervix, and then you get a little bit of the transformation zone here. This is a low power diagnosis. This is stromal endometriosis. It's very easy to miss. It's very easy to overlook. A lot of times the glandular epithelium may be endometrial over it and may not be. Sometimes it's just trauma. Sometimes it's true endometriosis. I think this is actually endocervical epithelium with a little squamous metaplasia, but it can look a little funny. But the key is to look at the hemorrhage, this edematous stroma, and the small little vessels. And what happens, and this one I think was a routine screening, but a lot of times this happens in areas where that have been previously biopsied or cauterized. And this can give you abnormal PAPs. Now, she had a positive HPV. Actually, I think I said 16. I don't know that it was 16. It might have been other type. But anyway, she had a high-risk positive HPV. So that is already going to make you suspicious when you're looking at a biopsy, especially if she had an ASK-H. And then you can see some of these cells and you can think, well, is this glandular neoplasia? A lot of times if they're actually endometrial epithelial cells, you see mites because it's proliferative. Depending on when they do the biopsy, you see mites, apoptosis, elongated nuclei. You could easily go down the tubes by calling it AIS. And we already know it's HPV positive. And P16 is often strongly positive, not typically as diffusely positive, but a lot of times it's positive. And so I didn't think the epithelium looked funny, and I went back to the PAP. So here's the PAP. It was called ASK-H, positive high-risk HPV. Those are clearly endometrial cells. Now, you only report them in patients that are over 45. So this, a woman this age, you wouldn't report them, but those are clearly endometrial cells. And then when you look around, there are some other kind of high NC ratio cells that I think now in retrospect are endometrial cells. So here they look a little more convoluted, bean-shaped. Notice that the chromatin is usually often pale or glassy in the middle of the nuclei for endometrial cells. Here's another one. Single cell that was identified, high NC ratio. But notice how these cells have kind of a ground glass, almost like polyomavirus in the urine, kind of glassy. I find that to be helpful in liquid-based preparation for single endometrial cells. Obviously, when they're a cluster, they're a lot easier. But notice the nuclear membrane is very dark, very like prominent nuclear membrane, but still thin and a very glassy kind of hollowed out side central portion of the nucleus. Now this is harder. And this would be a good ASK-H. I think the cells, but the cells really aren't that big. You look at an intermediate cell, the nucleus is about the same size. They do look a little convoluted, but notice how it's glassy in the middle. HSIL does not look like that. I'm not going to fault myself or someone else for calling this ASK-H. I think especially in the setting of an positive HPV, which, that's going to be our future as pathologists, is that we're pretty much only going to see PAPs in the setting of a positive HPV. It's going to be a reflex with a positive HPV high risk, non-16-18, because now that they're just going to probably do primary screening and transition to that, you're going to always be on high alert, and you're going to see stuff like this. You're going to overcall it all the time because we're not going to be used to seeing just normal endometrial cells because you're not going to see it as much. You're not going to see as many PAPs. But notice again, this is glassy. The nuclear membrane is kind of degenerated, almost like, wiggly looking around the periphery. But still, this could be, some sort of squamous lesion. But so now what do? I have the PAP. I think these were all endometrial cells in retrospect. I have cervical endometriosis. So you have to correlate that and put that in the report. And the reason that's so important to do is because you have to know the guidelines. So here are the guidelines for an ASK-H. So if you have an ASK-H, these are the 2020 most recent ASCCP guidelines. It says to manage per 2019 ASCCP guideline for women ages under 25 with histologic LSIL preceded by ASK-H or HSIL. So that's this, and then I, cut and paste. This is that management LSIL preceded by ASK-H. That's how you're supposed to manage these. So this is what I did, and which I think is what you should do. I reviewed cytologic, histologic, colposcopic findings. I made the conclusion that these are probably endometrial cells in the PAP. I said, this is not indicative that you missed it, because although LSIL regresses, that would be kind of probably as severe, like an HSIL SYN3, because of how high the NC ratio was if you really thought those were squamous cells, and they would go after it. And so what they would do, what they're supposed to do is they're supposed to do either cytology if the woman's younger, but this woman was over 25, so they do HPV-based testing. And let's say someone else, let's say another pathologist gets another PAP, they see she had this history of ASK-H, you did not identify that that was stromal endometriosis, you didn't correlate it, they get another ASK-H for another endometrial cell because they probably still have stromal endometriosis, and then they go on to a lead. And then someone else reviews the case and said, actually, no, this is all endometriosis, and this woman got, a 31-year-old got a leap, and now she has cervical incompetence, and she got a miscarriage, and that's another lawsuit. So, and I actually know a pathologist not unrelated to this, but I have a pathologist friend who's a very good pathologist who made the diagnosis of LSIL in a vulvar biopsy that was not a good call. I mean, it was kind of like cleared out, but they were not good coilocytes. But the woman had had a history of dysplasia, and they saw a lesion. It was really nothing. It was basically a benign vulvar biopsy, which most of them are, just like maybe a little like mechanical irritation kind of change. She called it LSIL. The surgeon, for whatever reason, did like a modified radical like vulvectomy for dysplasia. Yeah, that's, if you're dealing with clinicians, you're in Coos Bay, or this was actually outside of Austin, but in like a podunk town outside of Austin, which is most of Texas. The surgeon saw that report, said, oh, she's got dysplasia, did a vulvectomy at another location. They said, there's nothing here. They pulled the biopsy that my friend signed out. This was another pathology group. They said, we don't think this was LSIL. The woman sued my friend, and she got sued for that. And it was kind of legitimate. I mean, the surgeon should not have done what he did, but still, that's why I'm so like LSIL, like that condyloma and the older man that I showed you guys last month, or like, that's why I have such a high threshold for LSIL, because it really doesn't matter. You should only give the diagnosis if it's perfect, because you almost always regress. So that's why that is so important. So then here is what, this is what good, lots of endometrial cells look like. Often when they shed, clumped up, high NC ratio. Look at all these other ones, very bland, high NC ratio, kind of cleared out in the middle, little irregular. You don't care about these coffee bean irregular shapes. It's not indicative of an HSIL. And when you see it next to an HSIL, it's very helpful. This is a case that I saved because, oh, actually, this is another, see, I have all this shit on order. Oh no, this is the case. So this is a case where the woman has HSIL here and endometrials here. So you can see how different they look. And notice what I'm talking about this cleared out in the middle. See how it's kind of glassy? And look at the nuclear membrane. See how they're kind of dark? It's almost like, you know, I mean, I don't know if your generation colored much, used coloring books. You had all like iPads and shit. But what I used to do is I would take like a marker and outline the outside with like a blue marker and then take a blue crayon and color in the middle. That's what endometrial cells and glandular cells in general often in liquid-based preparation look like. It looks like someone took a dark marker and like went outside the nuclear membrane, and then the inside is kind of lighter and glassy. And look how that's not what H cell looks like. And let's find another.
The outer edge really is like a decoy cell.
Yeah.
Side by side.
Here's another good group of H cell. Again, notice it's very coarse chromatin inside. It's not glassy inside. Same. This is obviously good H cell, very irregular, hyperchromatic. And then here again, we have endometrial cells over here, H cell over here. So again, it's very different when you see them side by side. When you're just seeing them, you know, one to one alone, it can be hard to tell. Now, this is just to kind of go along this endometrial kind of path of discussion of things that you'll see. What's this?
Actino.
Actino?
Yeah.
Yeah, this is actino. Very filamentous looking bacteria. When you see that, what do you think that the woman might have in her uterus?
IUD.
Yeah, so then when you see these big endometrial groups that have vacuolated cytoplasm, you need to back the hell off. This is IUD effect. But these are often called agas if you either don't know, or if you don't suspect, or if you're not thinking about it. And you know, I've had several of these cases where you don't know that if the patient has an IUD when you get the PAP. They don't tell you that necessarily. You don't see that. So you have to kind of know. So it's seeing those groups with the vacuolated cytoplasm. And then this is the other thing. So look at this. The reason I can tell it's an endometrial cell, look at the nuclear membrane. See how it's like dark and like a linear, like a mascara around the nuclear membrane. And then the inside of the chromatin is very glassy. And look how high the NC ratio is. It's like almost like a lymphocyte high, but this is obviously much bigger than a lymph. And that's how you know these really high NC ratio cells are characteristic of women that have IUDs. In addition to the vacuolated endometrial groups. So then this is my last case on this kind of theme that I want to show you. So here, this is what, these can be hard. So I think these look like endocervical cells down here. These look more convoluted, irregular. They also kind of have a glassy nucleus, but they have more prominent nucleoli. Look how prominent those are. So this, you know, when you have really prominent nucleoli in a PAP, the differential is adenocarcinoma, squamous cell carcinoma, and repair. And so anything that's this kind of irregular and, you know, where you have some nuclei that have multiple nucleoli, and then, you know, very irregular overlapping groups. Most of the time repair is very flat, very kind of schoolfish looking, like school of fish looking. That's more indicative of something that's benign. When you have these groups that are really atypical, really prominent, distinct nucleoli, kind of a ground glass chromatin, this is adenocarcinoma. So then the differential becomes, are you dealing with endocervical, endometrial, or is this coming from somewhere else? And so if you're different, and you know, that I don't put too much pressure on myself. On histology, that can be a hard differential with stains to tell endocervical versus endometrial. A lot of times, you know, in Mass General, Dr. Scully, our big GYN pathologist, when I first was there, he was, old and about to retire, but he used to talk about how, he would call the clinician and say, well, where's the bulk of disease? And they said, oh, well, it's mostly in the endometrium. He said, okay, well, then it's endometrial cancer. And that was before we did a lot of these, special stains. But in this case, I think the thing that's sort of helpful is that, it's an older woman, and then you see cells like this. What do those look like? So these look like endometrial cells. Look how they're, look at the, polyoma virus looking cleared out nucleus with dense, prominent nuclear membrane. So the other thing that can help you is if you have an HPV, which all these women probably will, and the HPV is negative, it's probably not endocervical adenocarcinoma, because most endocervical adenocarcinomas are HPV positive, except for the HPV independent ones that are more like gastric, like adenomalignum, and those wouldn't look anything like that. They'd have a lot of cytoplasm and have like a low NC ratio. So that was an endometrial adenocarcinoma. All right, right along. Yeah.
I'm just curious what this is.
Oh, yeah. That's a good one. So Max has seen the slides, but he doesn't know the answers, but he's about to. So this is a 26-year-old man. This is a great case with a 3-month history of sinus congestion, thick postnasal drainage, pressure behind his right eye, obstructing right nasal cavity. Mass was seen on nasal endoscopy. A CT scan showed a polypoid and mass-like soft tissue lesion involving the right nasal cavity, which displaced the right middle turbinate. So they did a frozen section. I did not get this frozen section. This went to my colleague, Monty. I was not even here. It was like 2 o'clock. It's way too late for me. And so he showed me this the next morning. And he told me, hey, this is a 26-year-old with a big nasal polyp. I said, it's an angiofibroma, juvenile angiofibroma. That's what it is. And he said, well, look at it. I said, I don't care what it looks like. I said, that's what it's going to be. That's like the classic history. And then I looked at it, I saw these vessels. I'm like, yeah, I think it's a juvenile angiofibroma. And he said, yeah, but I don't know. I was picture matching. It doesn't really look like that. And I said, yeah, I think I have one in my recuts, but I was too lazy to get it. And so he's like, well, but what about all this stuff? I said, I don't know. They bleed. Maybe it's hyalinized, fibrous, whatever. He was just kind of descriptive and said, bland fibrous tissue, which is perfectly appropriate on a frozen. And hopefully if I had had my wits about me, I would have done the same thing if I had done this frozen and not just, put my neck on the line and said juvenile angiofibroma, which we took out the juvenile, but just nasopharyngeal or sinonasal angiofibroma. But I thought, these vessels, prominent vessels, the stroma look kind of fibrous, bland. It's pretty hypocellular, which in retrospect should have maybe caused me to have a little more caution. But, that's kind of what my working diagnosis was, because that's what I assumed it would be based on the demographics. So now here is a separate section. So, the other thing you could think about is like sinonasal Schneiderian papillomas. They usually aren't squamous like this. This looks like a metaplasia. Those have more of like that Schneiderian epithelium with the microcysts that have neutrophils in them. Here again, it's, starting to look pretty vascular. Look at, there's a lot of vessels that are very prominent. I did not send you pictures from this slide. Very vascular. And now the stroma is starting to look a little more cellular, a little more spindled. Here it looks a little more spindled. Again, there's some kind of metaplasia at the surface, which you'd expect for a big, polyp that's kind of there for a while and being traumatized. So big vessels, cellular stroma, not really very descript looking. It's kind of very bland, doesn't look like, there's some biphenotypic sinonasal sarcoma that has like muscle and S100 positivity. Those look much more cellular, like actual sarcomas. Doesn't look like that. I've never seen one. It's kind of newly described. I've been looking. I haven't seen one yet. Anyway, kind of not a whole lot to say about this. And then so he said, well, how would you sign this out? And that was one of the slides he showed me. I said, Yeah, I think it's an angiofibroma. I don't think they're called juvenile anymore. I say nasopharyngeal angiofibroma. And so and he looked uncomfortable. I said, just give me the case. I'll sign it out. So he gave me the case. I was dictating with Dragon, looking at it. And I'm telling you, I was about to sign this case out. And then this is the last slide. And I was like, Jesus, what's all this palisading? And I had noticed it on some of the other slides, but it wasn't as prominent as this. Now, palisading, you usually think about, if you see nuclear palisading, you think of what nerve sheath tumor? These, the Antoni A.
With
Schwannoma, exactly. But, in reality, there's palisaded myofibroblastoma. I've showed you spindle cell lipomas, GIST. There's tons of tumors that have nuclear palisading and are not schwannomas. And so I was like, oh, I'm going to have to start reading about, before I sign this out, let me read about nasal angiofibroma and see if they have this palisading. And I could not find anything about it. And then I'm like, well, let me look at this more. And Stanley,
this couldn't be like a basal cell adenoma.
no, those are more epithelial. This definitely looks stromal. So then I was like, if you start thinking that something might be a schwannoma, the next thing you should start looking at is the vessels. So then look at the vessels and see if they look hyalinized or like fibrinoid. And then I started looking at the vessels. I was like, oh my God, this is a schwannoma. So, and now schwannomas are common in the head and neck, but not in the nasal passages. They're like 3-4% of all nasal, of all schwannomas in the head and neck, which is an uncommon tumor, are schwannomas, are in the nasal sinus like passage. But this is not a bad age. 20 to 40 is usually when you get schwannoma. So if you want to prove that this was a schwannoma, what stain would be strongly diffusely positive? Yeah, so I got an S100, and that's the S100. Even the Veracay bodies, even are highlighted. I really averted disaster with this case. I am telling you, I almost signed this out. So I always get SOX 10 too, just because I like to get experience with it, and it's really nice also. So this is a sinonasal schwannoma, really rare. Not many have been described in this area, but thankfully it had that palisading. A lot of times in schwannomas, you don't see much palisading. You'll see kind of suggestion of kind of neural differentiation, but it's not that prominent. I think had it not been that prominent, I would have just blown it off as part of an angiofibroma. But there's several reasons why I shouldn't have. I'll go into that. This was a case I just had right before you got here a couple weeks ago. This was actually a soft tissue, sub-Q filling neck mass in middle-aged guy, and this is another schwannoma. I mean, schwannomas are very common in the head and neck. I had FNA'd several when I was a fellow. These often present kind of like lymph nodes, or maybe even if it's kind of near the face, like a parotid gland mass. And so it's something that you often see in the head and neck. They're very common in the head and neck. They're also very common in the flexor surfaces of extremities. Now, this is what an actual angiofibroma looks like. It doesn't look anything like that. Feel like I was so stupid. And then this is embolic material. So these are often embolized because they actually present usually with really bad nosebleeds, which this guy didn't. So that should have kind of been a tip off to me that it wasn't, but I didn't know the history when I saw the slide. I just know it was a 26-year-old guy. The other thing is the age is a little funny. So usually these are between 10 and 20. Almost all the patients, they arise from at 10 to 20. They may have them as they get older if they're not operated on. So that's why it wouldn't have been that unusual for a 26-year-old to present with it. He had the symptoms for years and didn't do anything. But notice how much more cellular and uniform the stroma is. There's no wall to these vessels. The stromal cells kind of just merge with the vessel walls, and they're kind of stellate, cellular. These are androgen receptor positive, kind of going along with the, they're almost all in 10 to 20-year-old boys, men. They're also beta-catenin positive, so patients with FAP have like a 25 times increased risk of developing these. And remember, with FAP, they may not have a history, like 20% or so of FAP patients are de novo mutations. So, and this could be the first presentation of FAP because they present young with these, and they may not have like GI bleeding from their tubular adenomas yet. So the other thing that would really be in the difference, yeah.
Do you routinely test patients with juvenile angiofibromas for FAP?
I've had 2 angiofibromas, so no.
Okay.
Yeah, no, but they should be. They should be because of the risk is so high. And they're very uncommon. So this is, I think, would be in the differential. And with what I had, if it didn't have all those varicate bodies that I didn't really even think of, these are, this is an antrochoanal polyp, which are very similar to inflammatory polyps, but they don't have the really prominent subepithelial basement membrane. They're much more fibrous, and they have less inflammation, less eosinophils. They do often have some eosinophils. You can see some here. But they usually don't have many. These are probably inflammatory. They usually arise from the maxillary sinus and then are very long and stalk-like and protrude into the nasal cavity. So antrochoanal polyps are much more common than a nasal schwannoma, and I think this looks like it could be a good Antoni B area. So this is probably what should have been in my differential before an angiofibroma in this case, honestly. Just to show one other spindle cell lesion that I've seen much more commonly than everything else I've described, even though you don't hear about them much. And these are glomangiopericytomas. These are, I've seen so many. I've never had my own. It's always been another pathologist in one of my groups that has shown me, and they have never known what this is. And it's because these are really not, it's not something you necessarily think about, but they are I think that they're fairly commonly found in the sinonasal cavity. They look like synovial sarcomas to me. They look very cellular spindle, but bland, no mitotic activity. It looks very uniform, almost like a translocation type sarcoma, very uniform, like really kind of all arranged kind of together, like, again, like a school of fish, very little mitotic activity. They often have those staghorn vessels. They describe in the literature that the staghorn vessels have perivascular hyalinization. I have never noticed that to be a prominent feature. These are CD34 positive. These are also beta-catenin positive. That's the mutation, I believe. Let me just show you one other one. See, now if you saw something like that, you'd think this looks like some sort of vascular thing. And that's because these often bleed and can have like almost like granulation tissue at the surface. But then when you look at other fragments, this is the actual mass, not that vascular stuff. Again, they all look identical. They're very uniform looking, very kind of spindled, but not long spindled cells, very bland, but yet very cellular. They're very blue, but yet they're not atypical. That's kind of the tip off to me. So it's a glomangiopericytoma. I'll just show you this last one. This is the last one I saw, and it actually had a lot of fat. You can get lipomatous glomangiopericytomas. They used to be called hemangiopericytoma, and they got rid of that name and called that glomangiopericytoma. And so this one has a lot of lipomatous metaplasia, which can be tricky if you just see this area. But then if you go to an area that has less of that, they almost look like lipoblasts. But that's part of the metaplasia in this tumor. But when you look at the nuclei, they still have that same kind of short, spindled look. And here it looks a little more typical of glomangiopericytoma. So I think these are, may recur, not really considered malignant. Same with angiofibromas. I mentioned this. They are benign, but they recur often, and they can undergo sarcomatous transformation. But it's almost always in patients that have been radiated because they keep recurring. They usually don't do that de novo. Okay, last case.
What do they turn into? Angiosarc?
No, not angiosarc, just any sort of like undifferentiated sarcoma. Okay, case 4 is a 54-year-old man, morbid obesity, non-alcoholic fatty liver disease, had a sleeve gastrectomy, still gained weight, so underwent another one. That's the only time here that I get sleeve gastrectomies is when it's a redo. So the lesion is this nodule. This did not cause his weight gain. This is incidental. 99% of the time, if you see an incidental stromal nodule in a stomach, it is a GIST. GISTs are one of the most common tumors in humans. About 35% of people have these microgysts if you did gastrectomies on all of them. But this one, to me, really looked like smooth muscle. So you can get leiomyomas. You just don't normally get leiomyomas. So, but to me, this really, really looked like smooth muscle. And it's because I felt like the nuclei looked identical to the smooth muscle cells, just a little bit bigger. Most GISTs have much more elongated nuclei, much more tapered nuclei. I just, you can notice you can get some little areas that look a little atypical, but you kind of ignore that unless there's a lot of it. But this looked to me just like a little leiomyoma. But just outnumber leiomyomas 50-1 in the stomach. So let's see. Here's CK. So there's actually quite a bit of staining, and it's not mast cells. They kind of look spindled, but they look like the cells in the actual muscular propria. Here's dog 1. Same thing, that same kind of spindle pattern. Maybe some of these are mast cells, but I don't think a lot of them are. And again, when you go to the muscle, you see those same, like probably interstitial cells of Cajal that are in the smooth muscle. So then, just cut to the chase. SMA was strongly positive. Here's Desmond. So that's a little leiomyoma. So this is just an incidental leiomyoma, kind of going with the theme of endometriosis, sinonasal schwannoma. These are all things that aren't necessarily supposed to be in these locations, and they're not the most common things in this location. But still, if you don't think about these kind of zebras, you're not going to catch them. Now, no one would just sign that out as a gist. Maybe an idiot would sign that out as a gist without doing stains, because it should be a gist. Now, this is a much bigger leiomyoma that I had. Now, leiomyomas are really, like I said, they're really uncommon in the stomach and small intestine. They're much more common than just in the colon, like especially rectum, and the esophagus especially. You can get leiomyosarcomas too. So in this, the differential is not just leiomyoma versus GIST, it can actually be a leiomyosarcoma. But this is very bland, low NC ratio, not a lot of atypia. You do not use the same criteria that you use in the uterus to diagnose a leiomyosarcoma. If you see like patchy, bad atypia, almost like a symplastic leiomyoma, and you see one mitotic figure outside the uterus in a smooth muscle tumor, that is probably a leiomyosarcoma. If you don't call it that, you're underdiagnosing them. So this was just a benign leiomyoma. Again, very pink. Now just here's a case. Leiomyosarcomas, they just used to be called leiomyosarcomas, and then they realized they were just and didn't call them that anymore. Now, when you do get a leiomyosarcoma primary in the GI tract, because you can get Mets, and by the way, if you get a leiomyosarcoma in the GI tract, more likely it's a Met, and you should think about uterine, and you should get an ER, because those are often ER positive. Whereas primary leiomyosarcomas soft tissue sarcomas usually aren't. They're much more common in the small intestine. So this is a leiomyosarcoma I had in the small intestine, where you can see the difference in the cellularity, the atypia, and then that is enough. Stop looking. It's a leiomyosarcoma. That's an abnormal mite. That's not just a mite, that's an abnormal mite. So that was a leiomyosarcoma. And then just for comparison's sake, here's a small gist. I want to point out a couple things with this gist. One is notice the nuclear palisading like a schwannoma. Schwannomas do occur in the stomach. Remember, I told you the other day that the thing to look for is like a lymphoid cuff in schwannomas, particularly in the GI tract. This has some lymphocytes, but this is a GIST. So you really want a lymphoid cup with like reactive germinal centers, but this is a GIST. Here's the other thing I want you to pay attention to. There is almost no stroma here. This is like a sea of cytoplasm, which is what they describe with GIST. Notice how elongated, spindled, really long the nuclei are, but yet they're bland. They're kind of palisading in areas where you see them lining up, and this is all cytoplasm. So I know I'm going to run a little late, surprise, but I do want to show you a case I had in December, just really quickly. This is a 72-year-old woman who had a biopsy-proven GIST, and this was a resection of her stomach. And I want to show you, there were like 12 or 13 nodules here. There's one, there's one, there's one, there's one, there's one, there's one. There were so many. I turned it over. There's some weird ass looking one. It looks kind of like a dumbbell. Here's another one that looks kind of multi-lobated. I cut them, very multi-lobated. Again, almost looks like a dumbbell shaped, bilobed. Another one here. Here's another one. Now these, when I saw these, I guessed, this was not done in our lab, I guessed that this was a metastatic melanoma. And I thought they fell for that c-kit. They did a c-kit, it was positive. It was on an FNA, like an EUS. I thought that they probably got a little bit of cell block. They saw spindle cell tumor. They assumed it was a GIST. They got a c-kit. It was positive. Remember, c-kit is positive in about 20 to 30% of melanomas. And so I thought this has got to be melanoma, especially with this dark look. So then I submitted a ton of sections, and here's one of those nodules. There's another one. Very spindled, very vascular too, kind of some palisading. Here it looks a little more epithelioid. Here's a little more epithelioid to spindled. And then notice this growth pattern, almost like an endometrial stromal sarcoma. It's multilobulated plexiform growth pattern. We're in the stomach. This woman is 72, very epithelioid looking to spindled. This could absolutely be a melanoma, but this is looking more like an actual GIST. It's kind of an epithelioid to spindled GIST. I'll show you one more slide. They all looked different. Very weird. Notice this growth pattern. This is characteristic of something. And again, these all look kind of epithelioid to spindle. These are very polygonal looking epithelioid cells. So I thought it was a GIST, so I got dog 1 was strongly positive, and then c-kit. This is 2 positive for melanoma. This is CD117. So this is like a multifocal, multilobulated GIST. Here's I did CD117 on another block also. It really highlights that growth pattern, that kind of, multinodular plexiform growth pattern. Now, I did a lot of reading about this case, and I read about GIST. And so when I did my report and I issued it, I said multifocal GI stromal tumor. This was the risk assessment based on the largest size. This is mixed spindle epithelioid type with a multinodular growth pattern. And I read that, multifocality of tumor, that the patient should be investigated for some sort of germline mutation, but she was old. It would be weird. But then I noticed I found a big study in the literature, and I said that most multifocal GISTs are sporadic, which I find odd, but that's what the literature said. But I still thought that that given the multifocality, that this woman maybe could behave badly, and so we usually send these for like molecular testing to look for a target. But at the same time, I also did an SDH immunostain. Now, we don't do those here. We had to send it out to Mayo. I have never interpreted an SDH stain in my life. So I didn't really know. I just figured, oh, it's an immunostain. So this is the SDH immunostain. So what you're looking for is loss, not positivity. So what do you think, Max? Positive or negative?
I think I want to see the control.
Let's see the control. You want to waste my fucking time? Is that what you want?
Well, no, because I don't know how it's supposed to stain. Okay, so
So that's the control that they gave. Here's the tumor. So I thought this was positive initially, and then I'm like, well, let me read about it. What's positive are the endothelial cells. And what they said, when they say in the literature, they say, go to the stomach and look at the glands. That is what is positive. This is actually tumor that is negative. And you see some granular staining, but for the most part, it's lost. And what you is a good internal control are the endothelial cells. So this is actually an SDH deficient GIST. And so just to show you, this is how I signed out the addendum, that this was an SDH deficient GIST. These can be sporadic, but they're more often, in this setting, they're more often familial. So she may actually be one of these very unusual patients that had an actual germline SDH mutation that presented very late. So for SDH deficient GIST, these almost all present under the age of 20. And they say that you virtually never get it over the age of 50. Well, this is an SDH deficient multifocal GIST that's in a 72-year-old woman. So it's really, really unusual. Now, if she does have a germline SDH deficiency, besides GIST, what's the other tumor that they get? It's Carney-Stratakis syndrome. They get paragangliomas. Now, that's with the germline mutation. With somatic mutations of SDH, that's Carney's triad, which is GIST, pulmonary chondromas, and what else?
pulmonary chondromas and
Same thing as
paraganglioma, right?
Paraganglioma, yeah. Exactly. So I just want to show you one more spindle cell tumor of the stomach, just so you have this in your differential for things. So very spindle, you would be thinking in the stomach, GIST, stomach, small intestine, common. Infiltrating into the mucosa, that would be weird for a GIST. Mm-hmm. Maybe it looks like it's palisading here. It's hard to say. It's very blue. You get these staghorn vessels, kind of like cholangioparasitoma. Do you remember the other staghorn vessel cellular sarcoma that's blue that you can get? It can be monophasic and biphasic. SFT has those vessels too, but this is a synovial sarcoma. You can get primary synovial sarcomas of the stomach. I've seen 3 of them. They're supposed to be uncommon, but I think they're underdiagnosed. You can get Mets, but you can get primary ones. They're often like 20 to 40-year-old. You would be thinking, again, this is a GIST, but they are usually c-KIT and negative, but they can be positive. They can be DOG1 positive. They can be S100 positive. So, you have to think of TLE3 or SS18, gene rearrangement to make this diagnosis. But the thing with these is, synovial sarcomas can be kind of low grade, high grade. They can be monophasic, biphasic. Most monophasic ones in the stomach, it's almost all monophasic in the GI tract if they're primary. They're usually not that mitotically active. Here's a mitotic figure, but they're usually pretty bland. You can get high grade synovial sarcomas, but the ones in the GI tract usually are not. All the ones I have seen have been recognizable as synovial sarcoma, enough that I've sent the fish on them. And then here's one other one. They can be kind of plaque-like. They can be transmural. This one's more plaque-like, kind of growing along. It's not the same growth pattern as a regular GIST. Maybe you could consider SDH deficient GIST. But the reason I focused earlier on the C of cytoplasm of a GIST is synovial sarcomas specifically do not have that. You see actually the kind of the fibrillary collagenous stroma in between the tumor cells. And that's the cytologic feature that distinguishes these from GIST, is that GIST is kind of all cytoplasm and nuclei. And this, with monophasic synovial sarcomas, you actually see stroma in between them. All right. Any questions? Do you have any questions?
I was thinking about that gist and wondering how you could exclude a weird metastatic pattern if this was a gist that was behaving weirdly.
Metastatic from where?
Well, like
Another
this gist can go, like if there was one of them was primary and it was just metastatic
Yeah, I think
inside the stomach.
it would, well, SDH deficient ones don't occur anywhere else other than the stomach.
Oh, okay.
So I think that actually helps me in retrospect. I don't think I necessarily could, but that would be, if you would think that the gist is metastatic there and they've already done imaging, they would have found the primary probably. It probably would have been big somewhere else. That's not something that should be like incidental.
Right.
So, but the SDH deficiency, those basically only occur in the setting of the stomach.
Okay.
And they always have that pattern is typical of them.
Okay. So
That
that's just what they do.
plexiform pattern is typical. Great. Adios. You want to say goodbye to Stanley? Where's Stanley? Come on, Stanley. Come on up. Okay. Wave goodbye. All right. See you guys next time. All right. Let's see.
It's hiding the end button.
Oh, it's up there. Yeah, that went okay.
Yeah, that's great. All right, buddy. Yeah, there's this one gist we